Thank you very much. I'd like to thank the organisers so much for inviting me here today, and I would also like to say how much I appreciate your very warm and gracious hospitality. I've been asked to talk about cardiac evaluation. One of the things we have to evaluate is how much the patient's comorbidity might impact on outcome. And we know that cardiac complications are a common cause of early morbidity and mortality. And actually, a significant number of our patients get cardiovascular complications post-operatively, and up to 25% of patients have some arrhythmia or even heart failure post-operatively. And one of the problems is that a significant number of patients being assessed for transplantation are completely asymptomatic. And that's because a lot of these issues are only evident once their cardiovascular system is stressed. And these patients are often very limited by their disease, and so they don't experience angina or breathlessness on exertion. So when we're evaluating patients, we want to determine whether they have any significant major comorbidities that would preclude transplantation. We also want to know if there's anything we can do to treat any cardiac complications pre-transplantation in order to improve post-op outcomes. We also want to think about any comorbidities that have the potential to diminish the likelihood of a good outcome. I think when we're considering the overall picture, we need to think obviously about the patient. We know certainly in the West, the patients who presented as candidates are increasingly older, they have greater medical acuity and have far more cardiovascular comorbidities than they ever had before. The surgery itself is a major hemodynamic challenge to the patient in terms of fluid shifts, potential for major bleeding, and obviously the issue of reperfusion. And then we need to think about the graft. We are increasingly confronted with much more extended criteria graft, more marginal grafts, and the donor risk index is important. And a patient with limited cardiovascular reserve will not cope well with a poor graft. So there are a number of guidelines out there. The most up-to-date are from the American Association for Studying Liver Disease, the 2013 practice guidelines, which are online, not published yet. And obviously the purpose of evaluation is to look for, in terms of cardiac evaluation, any evidence of coronary artery disease, pulmonary portal hypertension, HBS, valvular disease, and cardiomyopathy. And I put cirrhotic cardiomyopathy kind of in brackets because it's quite difficult to pick up. And there are very few outcome studies about cirrhotic cardiomyopathy, but it's increasingly recognized as an entity that actually impacts on patient outcome. So the first thing is all patients should have a baseline echocardiogram done, looking at ventricular structure and function, looking at valve structure, excluding any significant left ventricular outflow tract obstruction, and particularly to estimate the pulmonary systolic arterial pressure, because we need to pick up pulmonary portal hypertension. Very few of the guidelines actually mention how often echocardiograms should be done while the patient is on the waiting list. But at the Royal Free, we do it 6 monthly, because it is possible, if a patient's been found to have no evidence of pulmonary portal hypertension, some months down the line when they come for their transplant, they may actually have developed it. So we routinely re-echo them every 6 months. Now, portal pulmonary hypertension occurs in about 5% or more of patients, and it's not correlated with the severity of liver disease or with the etiology, but it has a very significant morbidity and mortality. So it's very important to pick it up at the initial assessment. And if the estimated right ventricular systolic pressure is above 45, and that's estimated from the tricuspid regurgitant jet, then the patient needs to have a right heart catheter done. And we know that patients with moderately severe pulmonary hypertension have a mortality of about 50%, and patients with severe hypertension, the mortality approaches 100%. And this is from Michael Krako's group, who've written extensively on pulmonary hypertension. And they suggest in this algorithm that patients with severe portal hypertension, they really are in a group where transplantation is probably precluded. Where you have moderately elevated pulmonary pressures, the important thing is to determine what the pulmonary vascular resistance is, because if that's higher than 240, it puts them in a very high-risk group, and those patients need very aggressive treatment with pulmonary vasodilators to try and bring that down. So that's a very important area to pick up just on the baseline echocardiogram. Another thing that's become apparent in recent years is that the influence of right heart function, and this was from the Chicago group, and they looked at the effect of right heart function, tricuspid regurg, as an independent predictive factor for outcome. And they got somebody to review the echoes of over 200 patients and to blindly grade the degree of tricuspid regurgitation. And the group of patients who had anything more than mild tricuspid regurgitation had significantly worse outcomes. So I think it's something that we really need to look at. And it makes sense because obviously graft function is affected not just by hepatic inflow, but also outflow. I won't say much about valvular heart disease or HOCM, other than that they must be picked up preoperatively at the time of the assessment. And really, if there's any significant degree of valvular disease that needs very specialist input, and in all cases, it can be associated with quite a high mortality, whether they're operated beforehand or at the time of surgery. And HOCM is another issue. There have been some case reports of patients having successful liver transplantation, but again, it needs to be managed by a very experienced team, and certainly not something to approach when you're just starting off your program. Now, coronary artery disease, for many years it was thought it was much less common than in the general population. We now appreciate it's just as prevalent in patients with liver disease. And in order to pick it up, we need some kind of stress screening. And perhaps the most generally used stress test is a Dobutamine stress echo. Now, if you look at the guidelines, they all suggest that if a patient has a number of coronary risk factors, then they should have a dobutamine stress echo. The guidelines vary in how many additional risk factors would make you go for a DSE. In these guidelines, they suggest 3. In others, it's 2, and others, it's even less. And probably what's more important than the number of risk factors is their relative impact. So diabetes and NASH would be more important than just the patient's age being over 50 or 60. The problem with DSEs is then they don't pick everything up and they don't have absolute perfect predictability. Negative predictive value is quite good, but positive predictive value is far less so. For instance, in the study by Findlay, of the 73 patients they did a DSE on, only 8 had a positive DSE, and only 1 had evidence on a coronary angiogram that they had significant coronary artery stenosis. But 14 of those patients had evidence of raised troponin postoperatively. So there are issues with DSEs. And as a result of that, some people actually push to do coronary angiography much earlier. And this is some guidelines from the Chicago, Pittsburgh, San Francisco group. And they suggest in their algorithm that if a patient has more than 2 risk factors, they probably ought to go straight for a coronary CT or ordinary angiogram. The problem with DSEs, although they're extremely helpful, is that in 30% of cases they're non-diagnostic because the patient does not reach the target heart rate. But actually, chronotropic incompetence is predictive of short-term adverse cardiovascular events in itself. The other problem is that even what we might consider non-significant stenosis, less than 50%, can, in this group of patients, be associated with acute coronary syndrome, because with the chronic inflammation, the high flow state, they're more likely to get plaque rupture. So I think we need to be very aware of coronary artery disease. We need to think about how we're going to screen for it, and any significant risk factors ought to trigger more invasive screening. The other thing I was asked to mention was cirrhotic cardiomyopathy. It's a well-recognized entity in patients with end-stage liver disease, but as I said, it's not generally used as an outcome indicator. It's defined as an impaired contractile response to stress with impaired diastolic relaxation and electrophysiological abnormalities in the absence of any other known cardiac disease. And it's essentially driven by the hyperdynamic state and the humoral and autonomic changes that occur. And as I said, the high cardiac output leads to eventually some ventricular hypertrophy, get changes from the chronic sympathetic overdrive leading to beta adrenergic receptor abnormalities. And it's a spectrum. But it has significant clinical implications. In terms of systolic dysfunction, there is an inability to meet the increased oxygen demand with stress and with volume overload. And so you can see problems when these patients become infected, after TIPS, and even during and after liver transplantation. The thing is that systolic function is normal at rest, but in response to stress is very attenuated. And although you can get it, the myocardium does not increase the cardiac output appropriately in response to increased preload. And so during exercise, there is a decreased aerobic exercise capacity. Diastolic dysfunction occurs because of the reduced elasticity of the myocardium, and you get electrophysiological changes, most notably a prolongation of the QT time. And it is definitely an issue, and this is from a paper where they looked at the response to volume loading at a time of maximum cardiac stress, i.e. 10 minutes after reperfusion. And patients with significant cardiomyopathy in response to an increase in left ventricular filling actually had a reduction in cardiac output. But you have to remember it's not an absolute contraindication to transplantation because it will improve after transplantation, but it may have implications for the early perioperative period. And how we pick it up, it is related to the severity of liver disease. It's probably worth measuring brain natriuretic peptide. It's a good marker of cardiac strain and ventricular overload. A prolonged QT is indicative of it. And also this chronotropic incompetence, failure to increase heart rate in response to stress. And the other thing on, for instance, stress echo is a fall of cardiac output with exercise. So clearly we need some other means of stratifying these patients. And one thing that people are looking at more these days is not just at comorbidities, but at their physiological reserve, their physical fitness. And age itself does not tell you about physiological reserve. It's your biological age that's important. And we all think we know what fitness is. These athletes are very fit, but how do you determine a patient with end-stage liver disease? How fit are they to undergo surgery? You know they have muscle weakness and wasting, malnutrition. So we need to look at the integrated response of the organ, and that's looking at functional capacity. Now, the very simple ways of doing that, people have looked at the 6-minute walk test, how far somebody walks in 6 minutes, and patients who can not walk more than 250 meters in 6 minutes have very poor outcomes. We do a simple stair test. We get patients to walk up 2 flights of stairs and measure their heart rate and oxygen saturations at the beginning and the end of the test. And some patients fail to put their heart rate up, some drop their saturation, and that gives us a good indication that we need to do further investigations. Now, cardiopulmonary exercise testing is a more objective way of looking at this. It looks at the integrated functional response to increased oxygen demand. And we know patients with end-stage liver disease have a decreased peak oxygen uptake due to reduced peripheral oxygen utilization from the poor state of their musculature. And in other types of surgery, that's been shown to be associated with an increased risk of perioperative complications. They have a lowered anaerobic threshold. That's the point during exercise where metabolism switches from aerobic to anaerobic metabolism. And it's submaximal and it's independent of volition. and it's indicative of a reduced oxygen delivery. There have been a number of papers on aerobic capacity in patients undergoing transplantation. And the first one was this one, which showed that a decreased VO2 and an anaerobic threshold is associated with increased mortality at 100 days. Then more recently, the group from Newcastle, Chris Snowden's group, looked at a number of patients, 60 of whom went on to have transplantation. What they showed was patients with a lower anaerobic threshold had much longer post-operative stay in intensive care, and that was highly significant. They also found there seemed to be a cut-off for survival. And of the 6 patients who died, 5 of them had an anaerobic threshold below 8.4. And the one death in the group above an anaerobic threshold of 8.4 was actually a patient who received a graft from an older patient with much more marginal graft function. And the King's group have recently also looked at this much larger cohort, looking at the relationship to aerobic capacity and survival, both patients who weren't transplanted and those who were. And again, they found on multivariate analysis that an impaired anaerobic capacity is both common and prognostically important and associated with outcome. They also found that hand grip strength was very well correlated with VO2 peak, so that could be used as a differentiator for who might benefit from CPET testing. You'll notice in the guidelines that tests of aerobic capacity are not formally included yet, but that the consensus is that they are providing valuable information, and that perhaps in due course they will be, but we need much larger trials and more data. And there is evidence that aerobic capacity can be modified. That's been shown in other types of surgery, and also studies in cirrhotic patients have shown that their muscle mass and aerobic capacity can be improved by exercise training. So, in conclusion, cardiac disease is a significant risk factor in patients undergoing liver transplantation. We need to be aware that it's often asymptomatic and occult, and we need to be very careful how we screen these patients. And finally, I think we need to consider not just comorbidities, but cardiovascular reserve and functional aerobic capacity. Thank you very much.